Now, as a second line, when the patients develop resistance for immunotherapy, unfortunately, they have to go back to the palliative chemotherapy. The most popular regime is docetaxel with or without Ramucirumab. That's very frustrating because there is a very low response rate, very short survival. That is why worldwide, nowadays, when a patient fails the immunotherapy with any of these 10 regimes I mentioned, we know that we cannot use any of the other regimes to rescue because we consider that all the checkpoint inhibitors are more or less equivalent, so we don't use one to rescue other. We are looking for new types of immunotherapy. For example, antibody-drug conjugates, new anti-CTLA-4s, anti-TIGIT, anti-TIM. Remember, PD-1 is only one type of checkpoint inhibitor. If you see the list of checkpoint inhibitors, there are more than 40 or 50. Meaning that the answer for immunoresistance is not in anti-PD-1, is maybe in the other 40-something checkpoint inhibitors that maybe we can use to rescue them. Or as I mentioned, another ways to do that is look for other types of immunotherapy like antibody-drug conjugates. Many industry partners are working antibody-drug conjugates. Everybody has their own antibody with many different payloads. That's another way that we can rescue people that fails immuno. So today, a patient fails immuno, we put in a clinical trial with one of these new approaches of immunotherapy other than the PD-1, anti-PD-1, and we have been successful rescuing them. Now, for example, there is already a presentation of phase 2 of Sitravatinib. Is an oral agent that targets regulatory cells. We know that sometimes immunotherapy resistance comes when the regulatory cells like Tregs or DSMCs upregulate and they damp the immune response. So that's why maybe the trick is instead to enhance the immune system as we do with anti-PD-1, PD-1, maybe the idea is to downregulate inhibitory cells, regulatory cells, so they can release again the immune system. Now, so for example, with this oral agent, we're doing a study now for 2 years with one of the industry partners, and we have patients that have failed therapy, immunotherapy, we put in the oral agent, and then we give the same immunotherapy, and it works again, and these are only examples of many other examples. Another example, not to be too long, I talked that we maybe have down-regulate regulatory cells. Okay, how about if we upregulate the immune response? When we give a checkpoint inhibitor, we upregulate the immune response. But that's not the only way that we can do that. For example, we can use stimulants of the immune response. And there are several interleukins, like we know for 40 years, interleukin 2, interleukin 10, interleukin 16. So sometimes when the patients fail the immunotherapy, now to spark again the immune response, we add an adjuvant, an agonist. And that agonist, as I said, can be one of these 3 interleukins. I mentioned this because I have studies with that. And basically, we have seen that adding the interleukin, you spark again, you erase again the immune response so we can rescue patients. So there are many ways to rescue patients. We also rescue patients with ADCs that are very popular drugs nowadays. But that's why it's very exciting field for us. There are many options that we can use now to rescue patients with immunotherapy. And I hope that this come for approval soon so the patients can benefit that instead of going to palliative chemotherapy with a very poor outcome,